This is my this is a first program from the US in this UroConnect. Here we wish to bring out programs or topics which everybody likes to hear, but and in developing the practices as well as knowledge. And we are trying to involve as many persons as possible, especially persons who are very much knowledgeable and this program is intended to continue, and hopefully we'll achieve great success. And regarding Dr. Prasant Nayak, we have nothing more to say about him. He's one of the greatest persons, both in mind and heart and knowledge. He had been to our West Bengal multiple times. I really hope the persons who have joined here will really enjoy this topic and that. Thank you, sir. What do you, Prasant Nayak, sir?
Yeah, thank you. Thank you, Dr. Soumya. Thank you, Dr. Prasanna, sir. Thank you, the Bengal Urological Society, for giving me this opportunity to deliver this first talk of this year. I think this topic is very relevant, as I was just talking with sir, that we need to know about this. So yeah, without much ado, let me start my screen. Let me share the screen. Yes. So yeah, share the screen. My screen is probably visible to the PPT. Yes. Is it seen? Are you seeing the screen now?
Yes, sir. Yes, sir.
Yes, sir. We'll see. Yeah. So so my topic is how does a urologist interpret a multiparametric MRI of prostate? So that is what I'll be talking about in next half an hour. How do we make sense of the report? There is a lot of disagreement even amongst radiologists, and a trained radiologist, a radiologist who is doing only uroradiology, actually would be able to interpret a mpMRI much better. So we are not going to get into that much depth. Only thing, once a report comes to us, once we have the images in front of us, or once if we have a CD of an MRI, then how to scroll through that, how to identify that, what they have identified, how to know, yes, how to corroborate, yes, this is the exact area of abnormality that they have been speaking about. So that is the idea of this talk, that how we understand their language and what they want to say, right? So why is it important for us to know about mpMRI? Because of three, four trials, in fact. There was a PROMISE trial that came in 2017, got published in Lancet. So that told that yes, MRI is really something that is of immense benefit whenever we do a prostatic biopsy. So rather than the traditional pathway of truss biopsy, the modern pathway, you do an MRI first and identify the areas that looks suspicious on an MRI, and then you target that. So that was so there are two, three more advantages of using an MRI. So I think all the residents must know these two, three trials. One was the precision trial, one was the PROMISE that came initially in Lancet in 2017. Then the precision trial that came in 2018. This was probably in your NEGM that came in, and the other important trial was 2019 that came as MRI first trial. So these three trials basically solidified the role of a multiparametric MRI of prostate in this biopsy pathway, in the diagnostic pathway. The role of MRI got solidified. That so the current understanding is, if I do an MRI, the current understanding is the MRI targeted biopsy as well as a truss guided systematic biopsy is probably the best option to have the maximum yield from it. The advantage of an MRI targeted biopsy, it picks up more clinically significant cancers and as compared to a truss biopsy alone. So there was some attempt to wean people from systematic biopsy and keep only targeted biopsy. In fact, there was a trial called 4M trial that also you should know about. So 4M trial probably concluded that there is no difference between between MRI targeted and the RUS biopsy, systematic biopsy. But at the end of the day, my practice in AIMS Bhubaneswar is that we do a MRI targeted and trust guided systematic biopsy both. But so yeah, so there are significant advantages of including this MRI targeted biopsies. So that is the reason why we should know how we read mpMRI and how to identify what lesions to target. So role of mpMRI. So PI-RADS scoring is a Likert scoring where it tells about the chance of having a clinically significant cancer, the prostate cancer. PI-RADS 1 is a very low, PI-RADS 2 is a low, PI-RADS 3 intermediate chance of finding clinically significant cancer. 4 is high chance, and PI-RADS 5 is a very high chance that yes, this patient or this lesion is definitely going to be clinically significant prostate cancer. Right. Recently, so PI-RADS has also gone through various iterations. So there was PI-RADS 1, PI-RADS 2. The current version is PI-RADS 2.1 that came in 2019. So this is the axial representation of prostate, which is relevant to us in an mpMRI prostate when we do. So as we take a cross section, I hope my arrow is seen. Yeah. So my arrowhead is seen here. So this is the base of the prostate. So this is the region of the base. This is the mid part of the prostate. This is the apex. So if you look at the base cut, when you see an ultrasound or when you see an MRI, so this is a base cut. So here this is the peripheral zone here. This is the urethra. This is the transitional zone. And this gray area on top is the anterior fibromuscular stroma. So this is how it will appear on an MRI. And this light gray area is your central zone. So as we go to the mid part, the central zone will not be there. Entire thing becomes a peripheral zone, transitional zone, and AFS or anterior fibromuscular stroma. Apex again, there is a peripheral zone, transitional zone, and there is a periurethral zone also, and there is an anterior fibromuscular stroma. So this is the anatomy in an apex, the mid zone, and the base of a prostate when you're looking at it axially. So this is relevant to us in interpreting the mpMRI. Okay, so 2.1. So PI-RADS 2.1 basically said for different areas of the prostate, we need to use the different sequences of MRI. So this is something that came up in 2.1 to identify a lesion in a cancer of the peripheral zone. So if you see here, this is a coronal cut. So this, this is a sagittal cut. So here you see this is the transitional zone of the prostate. This is the peripheral zone of the prostate. So for peripheral zone, the sequence that is most relevant is a DWI or a combination of a diffusion weighted imaging and a ADC. This is apparent diffusion coefficient. I will be explaining all that. So the whole idea is to explain all these terms so that you know what is DWI, what does it do, and what abnormality do we see. But what I need you to gather from this slide that a peripheral zone lesion, when you're doing a PI-RADS classification as 1, 2, 3, 4, 5, that is done based on a DWI ADC combination. All right, diffusion weighted imaging ADC. But when you're looking at a lesion in a transitional zone, a prostate cancer occurring within the transitional zone, the primary sequence which is important is a T2 weighted imaging in that area. So for a transitional zone, the T2 weighted is there. For a peripheral zone, a DWI. So what is the role of a dynamic contrast enhancement or DCE? DCE has a role to resolve an equivocal lesion in the peripheral zone. So suppose the peripheral zone, which by a DWI or ADC shows a doubtful area, it's a PI-RADS 3, which is an equivocal lesion. To decide whether it remains as 3 or goes up to 4, you need to do a DCE. DC is not typically used to resolve a doubt in a transitional zone. But if you see in transitional zone enhancement is occurring in a doubtful lesion, then that is a strong evidence or a proof or that pushes it towards a cancer. But if you have a doubt in the transitional zone, which is primarily by T2 weighted, if you have a doubt, rescue there is a DWI. So DWI ADC, you use it to clear your doubts in the transitional zone. I hope it is clear now. Transitional zone, you use a T2 weighted sequence. If there is a doubt, use a DWA ADC. Peripheral zone, primarily use a DWA ADC sequence. If there is a doubt, use a DCE, right? So these two lines, if you gather, this is important. So what is a T1 weighted? What is a T2 weighted? What we mean? So T1 weighted, this is how a spinal cord image. I just want you to appreciate how a T1 weighted looks, how a T2 weighted looks. Look at the fluid content. The fluid contents appears to be white or appears more intense here. So you can see here the spinal fluid here, the CSF is appearing white here, the CSF is appearing dark here. That is how you basically identify what a T1 weighted image is and what a T2 weighted image. Here the fluid appears to be hyper intense, or it takes up more intensity, right? Now let me come to DWADC. I will come to T2 weighted later, but this is the most important thing because most of the prostate cancers occur in the peripheral zone of the prostate, and the sequences important for that is a DWI and a ADC. So what does diffusion weighted imaging means? That means it quantifies the diffusion. It quantifies how much the water molecules can diffuse through the tissue, right? So that is basically diffusion weighting. So diffusion weighting means how much the water molecules diffuse through the tissue, right? Just a minute. Yeah, here. So how easily can the water molecule diffuse to the tissue? If you want to identify that, that is something called a diffusion weighted imaging. So how do you do this diffusion weighting? So you have something called E values. So to understand what is a E value, so E value is a strength of an MRI machine. You adjust the strength of an MRI machine, which makes or detects this diffusion of water more easily. Basically, you are decreasing the spectrum. So by increasing the strength, you are decreasing the spectrum of your view, and you are only trying to detect areas which have got a restricted diffusion. Meaning water is not able to freely diffuse through, so that area becomes highlighted. So as you go higher, the V values you increase, then the areas which have a restricted water mobility, that water is not moving freely, that gets highlighted. So that is called diffusion weighted MRI. The areas where water diffusion is not occurring freely, that area will appear hyperintense. So that is your diffusion weighted or DWI images, right? So that is what is key. So that means that area of increased cellularity, which is a malignancy, which is more cellular compared to the surrounding area, because there is a proliferation of cells occurring. There, water finds it difficult to weave in between these hypercellular areas. So because the water movement is restricted, diffusion weighting comes in, and that is why that area would appear as hyperintense, right? ADC, to be very frank, is opposite of that. ADC, what it does, it takes two B values. So whether B is generally taken as B0 and B1000. So they see between B0 and B1000, what is the change? So so a area that has shown restriction, there would be what you call, there will be less change, right? If you see a restriction area, that is hypercellular area where water is not able to freely move, there would be the gradient of change would not be there. So whether you take B0 or you take B1000, the gradient of change would not be much. So this is a quantification of the gradient while applying different B values. B0 you apply, B0 is nothing but a plain T2 weighted image. Then you apply restriction to that, you make it B values increase. You make it B700, B900, B1000, so that you increase the V values. So as you increase, you detect diffusion more. But an area that is not diffusion restricted, where water is moving freely, that area you would see more change. But suppose there is a diffusion restriction, there is no change. So ADC would So area which is having free diffusion of water, ADC would appear as a hyper intense area. I'll show you that in the next images. I think this is what is B value explained. It reflects the strength and timing of the magnetic field gradients. A higher B value sequence is more sensitive to diffusion, right? A lower V value is more sensitive to underlying tissue structure with a V value of 0 representing baseline signal without any diffusion at weighting. As I told you, B0 to B1000. So the diffusion weighted, it creates a signal that decreases when water molecule move between the gradient pulses. So I think let us understand with this image. So this is a tumor inside the brain, a hypercellular tumor inside the brain. Water molecules are not able to freely move in this area. So that is why this is on a diffusion weighted imaging. This area shows a restricted movement of water. So this restriction is highlighted when you increase the V value. So this may be a V value of 1000 where this picture is taken. So you see this highlighted restriction, right? But when you do an ADC map, this is the ADC map of the same thing, you are seeing the area which is restricted movement. There is no gradient change. There is no change whether you take B0 or B1000 because water is already restricted here. So there is no gradient change here. That is why this appears as a dark area. So areas of restricted water movement would appear as hyper intense on a DWI and it will appear as hypo intense on a ADC image. So this is what you need to remember. DWI, W stands for white. DWI, W stands for white. ADC, the D in the middle stands for dark. So DWI, W is white, ADC, D is dark. So you can see the dark color here. You can see a hyper intense. I think I have explained why it appears so. This is the area with water restriction. Restriction areas are picked up, are more hyper intense on a DWI imaging. So as I told you, prostate cancers are highly cellular with a densely packed glands in that area of cancer. This restricts the diffusion. On a DWI sequence with a high B value, generally taken at 800 to 1500, the tumor area would have an impeded water motion. Therefore, they appear hyper intense. You can see this area. This is appearing hyper intense on a DWI image. You can see this is the peripheral zone. As I told you, suppose this is a prostate cut. This is the central zone. This is the central urethra, the transitional zone, and this is the peripheral zone area. So peripheral zone, you can see this is a hyper intensity in EWI. Same area when we apply the ADC parameters. ADC parameter, you can see from 0 to 2000 here. Just a minute. So 0 to 2000. So somewhere between this to this, when you apply, so 0 to 2000, you can see here, this area appears to be dark. So ADC appearing dark, on a ADC map, right? So how do we score based on a DWI ADC scoring of a peripheral zone? So when you have a DWI score 1, there is no abnormality. So whether this on the left side is B is 1000, you can see B1000 is a DWI. This is an ADC map. So first, it's a good idea to look at the ADC. You look at ADC, this entire peripheral zone appears to be white. There is no change. There is no area which is appearing dark here. So this is a normal looking peripheral zone. This is a normal looking peripheral zone. Here also you do not see any area of an hyper intensity is not seen. So there is no abnormality either on the DWI or ADC. So this is a PI-RADS 1 lesion. Here on PI-RADS 2, you can see an indistinct low ADC area. Look at ADC first. You are seeing a dark area, but this is not forming a clear focal lesion. This is just a dark line here. So you are not seeing a focality, you are not seeing a rounded lesion, you are not seeing any contours here, just one area. So here also ADC, that area is not very apparent, not appearing very hyper intense here. So that is why it's not forming a clear focal area. So that is why this is a DWI score 2. DWI score 3, this appears moderately hypointense on an ADC image, but on a DWA image, it is isointense or very mild hyperintensity. So you do not see much change here on a DWA image. That is why you call it a PI-RADS 3, or it's an equivocal lesion. So lesion, so some diffusion restriction, but not a very marked. So it is not very clearly delineated. So these are the lesions which are equivocal. So this is the place where probably you need to do a contrast enhancement and see whether this area is enhancing. If you see a rapid enhancement and a rapid washout, that will say that yes, this area will get upgraded to a DWI4 lesion. Now come to 4. So what is important to us is not to miss this 4 and 5. You can see this again. Look at the ADC image. We can see a focal, markedly hypointense area in this part of the peripheral zone, which is on an ADC, it is appearing dark. And similar, when you look at this, look at the EWI, you will see a hyper intense area here. Rest of the peripheral zone appears to be dark. This area appears to be hyper intense here. So this is probably an area which is suspicious. If this area is less than 1.5 centimeter, you call it a DWA score 4. The same thing here, you can see a large area. On an ADC, it is appearing to be dark. As I said, ADC deep or dark. So you're seeing a dark area going beyond the capsule of the prostate, spreading beyond, and similar corresponding hyperintensity is seen on an DWI area. That is nothing but a DWI score 5 or a PI-RADS 5 lesion. I think it is clear now how what is the logic behind 1, 2, 3, 4, 5. So as we see more and more numbers, you will get more proficient in how to identify it. But you should understand what was the logic behind why we classified based on DWADC, whether it is 1, 2, 3, 4, and 5. So you can see here PI-RADS 4 or 5 lesion in a peripheral zone. So you can look at this image. This is a T2 weighted image. So this is a T2 weighted image, which is very good for looking at anatomy of the prostate and the surrounding structures. For identifying the anatomy of the prostate and surrounding structure, a T2 weighted image is an ideal. So first you look at T2 weighted. You can see here the peripheral zone is nice here. Here the peripheral zone has showing a dark area here. You can see that very clear. So this is that area that has been marked. So this is how it looks on a DWI image. So DWI, it appears white. So you can see the same lesion is lighting up nicely as an area of a restricted water movement. So that is a DWI image. Here the same area on an ADC, you can see how it appears. On an ADC, this area is appearing like that. So this is a 3D rendering. So some of the newer machines are able to give you 3D volumetric analysis. This is only in one cut, the E, but the F is showing that it's a complete 3D rendering. Okay, this entire area is the prostate cancer area, which is marked by an MRI. So this is again based on the size, it is PI-RADS 4 or 5. Now, when we are in this image, let me tell you also the difference between a chronic prostatitis and a prostatic malignancy. So here you can see this is a very capsulated lesion. It's a very focal lesion. So chronic prostatitis also would have inflammation in that area, edema would be there, swelling would be there. So water movement would be restricted area. So in a chronic prostatitis, again, it's a lesion that happens in peripheral zone, but it will be more diffuse. Almost the entire peripheral zone would appear to be dark in color. So that's why, and it will not be very focal. It will be very diffuse change involving the entire area of the peripheral zone. So that is how we differentiate between a chronic prostatitis or a prostatitis change compared to a change of a prostatic cancer. Right. So there is something called quantitative ADCs. So now when you have this ADC values, so there is a way to quantify, okay, this lesion. So what is the gradient of restriction that is happening here? So ADC that is more than 900 is likely to be benign, where ADC of less than 750 is strongly suggestive of a malignancy. Right. So ADC can give you these numbers. Okay. So a lesion appears to be that at restriction is at what level. So if it is more than 900, it is likely benign. A lower ADC value is strongly suggestive of an malignancy. Also, if this value is much lower, there is a higher chance of it being a more clinically significant. So there is a higher chance of a what do you call of a lesion grade group 4, a lesion grade group 5 lesion would have a much lower ADC value. So much lower. So there is some attempt to try to what do you call do a histological correlation between lower ADC values and a higher Gleason grade group numbers. So that is also possible, that has been attempted, right? So after this DWA-ADC, let me go to the T2 weighted image. As I told you, T2 weighted image is important for two things. It is important for anatomy, also important for looking at the prostate cancer in the transitional zone of the prostate. Okay, so T2 weighted, as I said, it provides the best anatomical detail of the prostate, clearly delineating the. So this is the T2 weighted image. You can look at the entire peripheral zone. You can look at the transitional zone. With this, these are the BPH nodules are there, right? So it shows a high signal intensity due to high fluid content is there in the peripheral zone, whereas the intensity in a transitional zone is more variable because there is a fibromuscular stroma there, some glandular element is there. So that is where the transitional zone would appear to be darker as compared to peripheral zone on a T2 weighted images. In a prostatic enlargement, in a BPE, benign prostatic enlargement, you can see here the transitional zone has increased in size and the peripheral zone is very narrow here. The peripheral zone has been pushed to the periphery. On a T2 weighted image, you can look at this anatomy and see, yes, the peripheral zone has been narrowed by this enlarged prostate, right? So how do you differentiate between a BPH nodule and a cancer inside a transitional zone? So both would appear similar, both would appear as hypointense, but you have to look at the margins. So BPH would have round circumscribed nodules. So it would have well capsulated, round, more roundish and more circumscribed. Whereas a cancer in a transitional zone usually is lenticular, like a lens, or it doesn't have any shape. It is amorphous, with the edges are not very distinct, lacks a clear capsule. So this is the main difference between how a BPH nodule or a cancer would appear inside the transitional zone. Again, you can look at this schematic. Here you can see this is the transitional zone, this is the AFS, and this white area, the peripheral zone. This is the BPH nodule. You can see round nodules with clear margins all around. Here, this is some area, some amount of haziness is there, area of low signal intensity compared to the surrounding nodules. This is appearing as lower intensity on a T2 image. So this is suspicious PI-RADS 2, but still you can see it maintains its round nature. That is why it is kept in 2. Here you can see in 3, it is roundish, but some margin is indistinct. Some areas are not very clearly seen. So this is this is hypointense, roundish with some margins which are not very distinct. So that becomes PI-RADS 3. Here more of lenticular, what I was talking, lens shape with all the margins are indistinct. It's again a hypointense compared to the surrounding nodules. So this is also called a charcoal sign because of its effaced margins all around. Just like you have a charcoal drawing and if you smudge it. So similarly, it appears as if all margins have been smudged, margins are effaced. So that is why it is called a PI-RADS 4 lesion. PI-RADS 5, again, there is a very amorphous kind of lesion, maybe breaking through the transitional zone and surrounding and encroaching into the surrounding zones with a irregular or diffuse margins all around. So that becomes a PI-RADS 5, right? So either it water drop shape lenticular involving the AFS or the anterior horn of the peripheral zone. So either it has come into the peripheral or there's a large one amorphous lesion with indistinct margin that becomes a PI-RADS 5. So this is the PI-RADS 5 lesion. You can see a large PI-RADS 5 lesion. You can look at the surrounding transitional zone, how much hypointense it appears to the surrounding area. So, so this is a T2 weighted large image. So although it is not breaking through, so it is not breaking into the AFS, not getting into this peripheral zone here, confined to the transitional zone, but you can see the margins are not very distinct. So this will be almost a PI-RADS 4 or a PI-RADS 5 lesion here. So this is the DWI. So whenever in doubt, suppose you have a PI-RADS 3 lesion here, you want to see whether it's a PI-RADS 3, you look at whether that area has got restriction. So you do a DWI, look at the rest of the BPH nodule or rest of the transitional zone where normal nodules are there, benign nodules are there, and look at this cancerous area. How on DWI it will just glow like that. So a white area on a DWI within a transitional zone, again, this clears your doubt whether this is a malignancy or a BPH nodule. So as I told you earlier, transitional zone, look at it heat-weighted image primarily. In case there is a doubt, you do a DWI and an ADC. DWI, this area appears to be white, showing that there is a restriction. ADC, this again appears to be dark, showing that there is a restriction there. And this is the 3D rendering, showing the entire malignant contour or that entire area of involved by the prostate malignancy or the entire volume of the prostate cancer. It is shown here. Right. So coming to T2 weighted image in the peripheral zone. Prostate cancer again appears as focal areas of dark signal on T2, as I told you earlier. This is due to tumor dense cellularity, lower water content. So there is a greater reduction. Suppose in T2 in peripheral zone appears to be too much hypointense. There is some article to say that they correlate with a higher tumor grade. As I told you, ADC very low values, or in T2 it is appearing too much hypointense. That again indicates a higher grade or higher Gleason grade group of the prostate. So it helps to confirm. So what is the role of T2 weighted imaging in a peripheral zone? It helps localize the lesion because you get good anatomy, and it helps confirm and localize lesions that you primarily grade, or you do a PI-RADS grading based on the based on the EWI, but it's just a confirmatory to see that okay, yes, this is the area that corresponds and this is the anatomy of that area. Okay, as I said, T2 when I T2 weighted imaging is a most important anatomical imaging. So to identify the stage of the tumor, once you identify, yes, this is a malignancy, you have identified the lesion, but to look at areas like extraprostatic extension, look at neurovascular bundle involvement, look at seminal vesicle involvement, bladder neck involvement, all these things are done on a T2 weighted imaging. So T2 weighted imaging, either you can do axial cut, coronal cut, you can look at the sagittal reconstruction. So uh, all those cuts on a T2 weighted image, you can comment on the anatomical extent, and the local staging of this cancer can be done on a T2 weighted imaging. So that is the other role of a T2 weighted image on a prostate cancer. So here you can see here. So again, this is a lesion primarily arising from the transitional zone, entering into the anterior fibromuscular stroma, and it's a diffuse lesion here. So you can see, but still confined within the prostate. So it's a T2 lesion, probably involving both the lobes. So it would be T2B, and but not breaking through. There is no extracapsular extension here. Still the capsule is intact here, but entering into the AFS. So this is the lesion here. A lymph node. So a lymph node also can be detected on a T2 weighted imaging. So this is again a peripheral zone. When you look at E2 weighted imaging, this is extending into the neurovascular bundle. So neurovascular bundle involvement typically it's in at 5 o'clock and 7 o'clock. So you look at this image. This is the top. This is the bottom is the rectum. You can see here around 7 o'clock area. There is an extension into this. This entire tumor is coming out. Compare both sides, and this is probably indicative of a neurovascular bundle involvement here, right? So if you are planning your surgery, you wouldn't want a neurovascular protection on this side. So this is again showing on a sagittal section. You can see the bladder neck involvement and also involvement of this lesion into the seminal vesicle. So again, so anatomical extent, involvement of the bladder neck, involvement of the seminal vesicle is best seen on a T2 weighted imaging. How do you know T2 weighted? You're looking at the seminal vesicle fluid, you're looking at the bladder urine, all that is appearing white. So this is a T2 weighted image which is showing this anatomy of beautiful anatomy of showing extension of prostate cancer into the neck and into the seminal vesicle. So again, T2 weighted is good for imaging anatomy, but they're not specific for cancer. Many benign conditions like fibrosis, post-biopsy hemorrhage, stromal BPH, highly stromal nodules, prostatitis, they all can appear hypointense, isointense on on E2, right? And some small malignancies may not be picked up on E2 at all, right? So it is invaluable or very important for anatomical localization and for transitional zone, but it must be interpreted along with the EWI and DCI when it comes to the peripheral zone to get a accurate diagnosis. Now, as I told you, the role of DCE involves a T1 weighted image. A DCE is done on a T1 weighted image. So you do during and after intravenous gadolinium contrast injection. So you give gadolinium, the small areas would show up. You can see. So, so these have tumor would have angiogenesis. So they'll have strong contrast uptake compared to the surrounding normal tissue with a rapid washout. So you can see here this area lights up and then immediately it goes down. So you can look at the DWI corroboration, the ADC with a DCE image. So here this is a picture with an enhancement that is seen on a ECE. So DC enhancement is seen here, corroborated by a DWI and an ADC also. Right. So normal tissues in contrast will enhance slowly and to a lesser degree with a very slow washout. So that is how we differentiate from basically DC is again, as I told you, PI-RADS 3 lesion in a peripheral zone on a DWA and ADC where there is a doubt, you do a DCE. DC is not used for transitional zone, although this image I've shown of transitional zone because this is a very good image here. But again, it is role of DC is an adjunctive to resolve equivocal DWI findings in the peripheral zone. In an indeterminate peripheral zone, a positive DCE will raise the lesion to PI-RADS 4. If no enhancement is seen, DWI 3 lesion would stay as PI-RADS 3 lesion. So you would not upgrade it to PI-RADS 4, it will remain as a PI-RADS 3. In transitional zone, it is not formally part of the scoring algorithm. It is not directly changed by DCE. But if a transitional zone does so focal enhancement, it adds confidence to your assessment that yes, there is an abnormal focus and there is a chance that this could be a malignancy in that area. What is the role of a T1 imaging? As I told you, T1 imaging is used when you do a DCE. Otherwise, it can also detect intraprostatic hemorrhage. So post-biopsy blood appears hyperintense on an E1 weighted image. So probably that is the only role of a T1 weighted imaging, either as part of a DCE or a T1 weighted post biopsy. You can see that hemorrhagic area here. So that's the idea of a T1 weighted imaging on a mpMRI. So T2 weighted is focal ill-defined hypointensity, often in posterior to posterolateral peripheral zone. So so as I told you, it's an anatomy. You identify, okay, this is an abnormal area in a peripheral zone. That abnormal area you confirm using a DWA-ADC. This is for peripheral zone. So T2 weighted is to identify an abnormality anatomically. DWA-ADC, you look at white area and dark white area on the DWI, dark on ADC, yes, and you confirm that it's a PI-RADS 1, 2, 3, 4, 5 based on this. DC, if a PI-RADS 3 as per DWADC resolve, you use a DCE. I think that is the summary of a peripheral zone tumor. For a transitional zone, T2 weighted primarily. Okay, there is an ill-defined, margins are not very clear, extending into AFS, extending into the horn of the peripheral zone. So, and hypointense lesion compared to the surrounding area, that's a abnormal area and on a transitional zone. How do you confirm? Look at DWADC. That image would show a white or a black area, white on DWA, black on ADC. Within transitional, with surrounding adenomatous area would be normal on a DWADC. Then you know, yes, this is a cancer, right? So that is for the. So what is the probability? So 12% that the lesion is a clinically significant lesion. So probability of finding a lesion more than or equal to 7 cancer is around 12% if it is a PI-RADS 3, goes up to 60% if it's a PI-RADS 4, and up to 85% if it's a PI-RADS 5 lesion. So that is the idea why we say that MRI targeted biopsy picks up more clinically significant prostate cancer. However, MRI can miss intraductal carcinoma. Intraductal carcinoma, there is not a single focal lesion, but it's a multifocal and a diffuse mass. That's why it may not light up as a distinct focal lesion. So that can be missed. Very small lesion, 7 and 8, less than 5 mm, there is a limitation. It may not be resolved adequately on an MRI, and you might miss on an MRI. So, as I said, anything more than 5 mm up to 1.5 mm, you can put it PI-RADS 4, more than 1.5 centimeter, it goes as a PI-RADS 5 lesion. So when you have an MRI report, this is how a typical MRI report should read, that it is showing a PI-RADS 5 lesion in the right mid-peripheral, highly suspicious for a significant prostate cancer. No additional lesions, no MRI evidence of extension, recommended TRUS MRI fusion biopsy of the right mid-peripheral zone lesion. No MRI evidence of clinically significant. If there is nothing is there, no MRI evidence of clinically significant, PI-RADS 1, 2 findings only. And look at all these things we mentioned: extra prostatic extension, seminal vesicle involvement, lymph nodes. Look at all the bony areas within that MRI, pelvis and other adjacent organs if they are involved. So this is 2.1. As I said, these are some of the changes that happened between 2 and 2.1 in 2019. The overall goal is, you guys can go through that. I'll be sharing this. So all these points I've already mentioned in my talk. So the overall goal of 2.1 was to improve inter-reader agreement, to reduce the ambiguity, increase the accuracy of this prostate MRI reporting. So by providing specific and standardized criteria. So that was the whole crux of this. So thank you very much, and hoping to see all of you in Uro-Oncology in May 22-23 in AIMS Bhubaneswar. Thank you. Thank you. I think I'll stop sharing my slides. Yeah. Thank you, sir. Thank you.
Excellent presentation, Prasant. In fact, we learned a lot of things. Some questions have come in the chat box. Let's see them.
Yeah.
Is there any correlation with PS and MRI PI-RADS? That I believe you covered that.
Yeah, so as far as PSA, higher PSA is more with clinically significant prostate cancer. If you believe in that, then yes, a higher PSA, more clinically significant, then you will have more what you call glaring findings on an mpMRI. Yeah, so that way. Yes.
Hello.
Yeah.
Good evening, Prashant sir. Saranjit here.
Yeah, hi,
How are you?
Saranjit. Good evening. I'm fine. Thank you so much.
I've got a query. Sorry, I missed initial 10 minutes presentation. I don't know whether you have explained.
Yeah.
Suppose you have picked up the malignancy after post-URP.
Right.
How long you wait for the MRI? The MRI to stage the malignancy.
So 1 month. So 1 month is adequate. So suppose you have started treatment for chronic prostatitis, wait for a month. Even if you have done it URP, wait for a month. Even if you have done a prostate biopsy, wait for a month. So that is what is the recommendation.
Goal is around 4 to 6 weeks, right, sir?
Yeah.
Another tricky question, although I don't know whether I should ask it. It's a
Please
heated
ask.
debate. Yeah, I do know you will have a session in Uro-Oncocon. Whether in near future a 3T MRI properly structured can replace in few selected cases a TRUS biopsy or a fusion biopsy in the future. Because
So,
these things keep on cropping up in AUA and BJUI
yeah. So as of now,
every
there is
now and
no
then.
As of now, there is no trial where they have not done biopsy. They have always done it, and then they have come back. Yes, we could have avoided in
That
certain
is
subset of
the
patients.
whole reason.
Yeah,
Yes.
agreed. So yes, it might in future. So if you have more robust data coming, like I said, ADC values you look at a PSMA PET correlation. So do an mpMRI, do a PSMA PET. There is something that is coming up is PSMA PET MRI now. So if you
Exactly.
have a PSMA PET MRI, that is a fusion of both PSMA as well as your other MRI. Yeah, maybe things will change. Yes, yes,
Good evening, Prasant sir. Dr. Purkar here.
yes,
Uh,
yes,
Nowadays, we usually prefer mpMRI before
yeah,
doing biopsy in grade 1 PSA. But
yes.
most of the time, we now see that physicians, especially the oncology, the patient go them, they will start first the PSMA PET CT whole body. Is there any correlation between the MRI prostate or PSMA prostate, or if when should we do? If MRI is negative but still PSA high, or PET scan is negative, is there any correlation or there any study?
So, no. So the only way where you will do a PSMA PET as of now, you have done an mpMRI guided biopsy. Biopsy has not picked up any malignancy. You have kept the patient on observation. PSA is still rising. You are not clear what it is. You want to do a re-biopsy in that patient. Then there is a role of you get a PSMA PET, get some additional corroboration. Now we are also having PSMA PET guided biopsy. So that is also
Okay.
something that is coming up. In AIMS recently, they have put a robotic biopsy. So PSMA PET guided robotic biopsy they have started. So they have got a robot and all that. So again, these are all areas. So beyond the initial management, so initial management pathway is now mpMRI followed by a truss guided, targeted plus systematic prostate biopsy. That doesn't pick up anything. Still, you have a high clinical suspicion because of rising PSA or whatever money reason. Then you need to go into PSMA PET and get a PET guided biopsy. Yeah.
Okay, sir. Thank you, sir.
Sir, we have some questions from students. They are common the ch chat previews. Can we answer
Chat
them?
box, yes, can I see? Okay. Yeah, I will share it. So role of biparametric MRI. Okay, in CKD patient, yes, as I said, DC is not at all important. So DC is not important. So the relevant sequences are only DWI and E2 weighted images. So that is all that you need to do. So just do a E2 weighted and this thing. DC is only to clear your doubts. So most of the times you wouldn't need. So is there a need to resolve a PI-RADS 3 lesion? Suppose you have a PI-RADS 3 lesion. That is probably the only role of of using a contrast. PI-RADS 3 lesion, you can again use the PSA algorithm. Look at PSA density. Suppose PSA density is high, then again you go ahead and do a biopsy, irrespective of what the PI-RADS scoring is. So suppose you're stuck with a PI-RADS 3, look at PSA density rather than going for a dynamic contrast enhancement, and then you can follow that pathway. So if you look at your current EAU 2025 guidelines, it very clearly says that how to use PSA density when you're stuck with a PI-RADS 3 lesion. Yeah, so you can use that there. Role of biparametric. Please, can you elaborate an MRI first or biopsy as per, as I think we have already discussed, MRI first always. And okay, so suppose you have a frankly metastatic PSA is 1000 and you have a nodular prostate. I don't do an MRI. I straight away ask my residents to do a finger guided biopsy, 3 or 4 or 5, 6 hours you take and confirm it. That is all we needed. But that may be the only clinical scenario where I would omit an MRI. Otherwise, all other patients would get an MRI. Yeah. Biparametric MRI, I have already told. Yes, is there any role? MR scintigraphy, I'm not aware. I'm not aware. MR scintigraphy, I'm not aware. Yes. Yeah.
Thank you,
PSMA,
sir. Any...
yeah.
Okay, sir. Please continue.
No, this PSMA and high PSA, I didn't get the question. High PSA, low PSA, whatever it is, you get an mpMRI one. So again, the traditional or the route is get an mpMRI, look at the lesion, PI-RADS grading, do a targeted and a systematic biopsy, and only then PSMA PET. I don't think there is any pathway where you do PSMA PET guided unless there is a doubt on an mpMRI guided. As of now, yeah. Suppose PSA is 27, DRE is grade 2, mpMRI or repeat PSA, and do an mpMRI. So why do you want to do repeat PSA weight? You need to resolve it in a patient who is less than 65, is surgically fit, is a candidate for this thing RP or RT, RP or this radical RT. Then again, you do an mpMRI. Why do you want to wait and repeat PSA? So all PSA needs to be repeated. So a single PSA report is not accepted. Repeat it 2 times. But in the consensus is now you can repeat it immediately. You do one PSA today, tomorrow another PSA. You are only ruling out a lab error. You are not looking at prostatitis and all that. You're looking at a lab error. So do two PSA, and then if it is elevated, you go ahead and do an mpMRI. Yeah.
Prasant sir, one small question here, Dr.
Yes.
Purkai.
Yeah.
What is the current role of digital rectal examination? It is mandatory, desirable, or optional in the era of high resolution imaging, especially in gray zone. Does your DRE change the management in absence of MRI or PET scan?
DRE is for 2 things I do. One is to look at prostatitis. Patient has a painful prostate, so that is what I rule out using a DRI, using a DRE. If I see an obvious nodule, PSA is low. In spite of that, patient would get an mpMRI, and then we would do a biopsy. That is for other reason. Third, very anecdotal reason. General surgery has referred patient, and without doing a DRE, I have found a sphere rectum when I've done DRE on them.
Prashant boss, hello.
Yeah.
Regarding follow-up of your previous comments, you told back-to-back 2 days you can do a PSA from 2 separate labs and then go for mpMRI.
Yeah.
In Indian scenario, chronic prostatitis is actually the norm rather than exception.
Yeah.
So where comes your role of and then antibiotic use and then repeat the PSA? If you are doing back-to-back today and tomorrow PSA, then when you are giving antibiotics?
So yes, so this back-to-back PSA is only for confirmation of that abnormal PSA value. This whole idea, it is not even today and tomorrow. Today also, if you get from 2 different labs, that gives you confirmation that yes, this PSA value that came, that is really abnormal. That is the whole idea about this 2 PSA report, right? That you are confirming. If you have a doubt, so when there is a doubt, suppose PSA is in the gray zone, 4 to 10, so-called 4 to 10.
That is what.
Still, I would do an examination, rule out acute prostatitis. There is no acute prostatitis in that patient. I've done a DRE. I'll go ahead and do an MRI. So anything more than so, nowadays the PSA cutoffs are also age-specific cutoffs. So suppose more than 50 years, we have a cutoff of 3 now. So we are taking a cutoff of 3 at AIIMS Bhubaneswar. So we are not taking 4. More than 3, I get an mpMRI done. Because mpMRI gives you such a clear picture. It tells you what that is, whether it's a clinically significant PI-RADS 4, 5 comes, I will do a biopsy for that patient, irrespective of what the PSA is. This idea of chronic prostatitis comes, suppose PSA is 8 or 9 or 10, 12, do an MRI. MRI is also not able to give me PI-RADS 2, PI-RADS 3 lesion. Okay, so then I know, okay, this may be prostatitis leading to false elevation. MRI is shown a PI-RADS 1 or PI-RADS 2 lesion. Then I will give antibiotic. That is one.
Then you will repeat the MRI after 3 weeks?
No need. I will just give an antibiotic, look at PSA falling down, PSA falls down. I know that, okay, this was probably not a malignancy, but even after antibiotic, it is high, I would go ahead and do a biopsy. That is one. So high, again, because as I told, radiologists also, you need to have expert radiologists who can comment upon this MRI report. So you have to take this PI-RADS scoring also with a pinch of salt. That's the whole idea of this whole exercise, is that we should be able to give some inputs rather than solely relying upon the radiologist.
And what is your protocol? Although it is not part of the discussion, it is follow-up discussion. What is your protocol at AIMS Bhubaneswar? Is it 16 core biopsy, 12 core biopsy? How many cores?
So it is 10
Standard.
core biopsy. So 10 to 12 core biopsy we take. If the gland is larger, we take three more on each side. So 10 then plus 3 becomes 16 cores. So that is how it is. Only thing is, in addition to the systematic biopsy, we will MRI guided biopsy.
Targeted biopsies.
Targeted biopsy from both umbral and penumbral region. So there are articles to read on umbra and penumbra. Umbra is the dark center of that lesion. Penumbra is just the surrounding part. So try to include biopsy from both the umbral and the penumbral areas. Yeah.
Definitely.
Thank you, sir.
Prashant sir,
Thank you. Yes. Sir.
Prashant sir, if there is a raised PSA, just raised PSA in a large prostate which is benign digitally, and if a prostatic biopsy is done by ultrasound guided rectally, and it comes up to be benign, how do you follow up? Do you do prostatic density, PSA density, or do you just repeat again with MRI and follow up with the repeat biopsy?
So ideally, all biopsies should be preceded by an mpMRI. If that was not done and a good systematic biopsy has shown that it is negative and patient has a very, obvious enlargement, I would probably look at PSA density. Again, the size as measured by MRI is probably the most accurate. Ultrasound size measurements also are not very accurate. So whenever I talk about this size and PSA density, you should look at the size measured by the MRI. Probably that gives the best anatomy and best size of the size measurement prostate as compared to ultrasound, which may be way off. One report you'll see 25, another report you'll see 45, 55. So frankly, I don't believe the size and ultrasound. Yeah, so PSA density in those patients, yes. And then I will keep following up the patient, looking whether PSA is rising. If there is a rising trend, I would go ahead and do an MRI again and do a biopsy.
So do you still believe in PSA velocity?
No. So only parameter or only PSA derivative currently that we follow is PSA density. After MRI has come in, I think all the other PSA derivatives are kind of outdated. We should do away with that. So MRI, PSMA PET scan, these are all options now. PSA density whenever there is a doubt or your initial biopsy has not shown anything. Yes.
Thank you, sir. This is Dr. Shashi, sir.
Yeah. Hi, Dr. Sir.
Thank you, Bhushan sir. I believe in the anybody else has any question, you can come up. Otherwise, we're going to pack up now.
Yeah,
So,
I think we will
nice
have
presentation, sir. Nice presentation, sir.
Thank you.
And we are really happy.
Soumya, I'll send you the PDF of this entire PPT. You could share it with your residents if they.
Yes, sir. Bhushan sir has been kind enough to share these PDFs. So somebody was asking for it. You will be getting it in the group.
Yes.
And what to say, Les, sir? We'll expect you in further classes.
Yes. Thank you. I think this is an honor for me. Thank you.
Thank you, sir. So kind of you. Thank you, sir.
Thank you.